So what are people's thoughts in the wake of the Pacific trial? Should we do a Pacific small cell trial?
They're doing it. It's called ADRIATIC.
I know.
I think that it may not accrue as quickly as Pacific
Well, I was going to say,
did.
do we know the status of that?
Will it be a sea
It's
change?
open. It's open to accrual.
Okay.
Yeah.
We're opening it at our institution at the moment. Those patients are definitely not as common, but
And remind me of the design, the exact design. Is it very much like Pacific?
it is identical to Pacific.
And
So
how-
concurrent chemoradiation therapy, and after patients are going on durvalumab versus they're not getting it with they're
4
not doing
cycles?
it with.
But are they getting 4 cycles of chemo? Because I think that's one of the challenges is that for locally advanced non-small cell, we're comfortable with this idea that if you give 2 cycles of cisatopicide, that's adequate because we've not been able to show that giving additional chemo is beneficial. But in small cell, we always give 4 cycles for
Right,
limited.
but I don't know what the trial design is, but I would be comfortable in a small cell patient giving the radiotherapy starting cycle 3.
Yes.
And doing that and then starting the immunotherapy. I don't know if that's the design or not.
I think Nevin Murray had done a randomized trial from Canada, British Columbia, 2nd versus 5th cycle.
Right.
And that showed superiority of 2nd, but 2nd versus 3rd may not be that different.
Well, we did, back when I was at Carolina, one of the radiation oncology residents did a meta-analysis, you know, that old saying, you never meta-analysis you didn't like. This was in small cell, where we looked at early versus late. And early was defined as any time starting radiotherapy in the first 3 cycles. And there clearly was a benefit. It was not necessarily magic to give it cycle 1, but early on in the course. So I think the data would support a cycle 3.
Yeah, and you know, we've recently completed a small cell limited stage trial of chemo with radiation and pembrolizumab at the same time. And you know, in small cell, the toxicity is even more of a concern. First of all, patients tend to have more comorbidities, worse pulmonary function, but the radiation fields tend to be larger for small cell as well because you really have to radiate more of the mediastinum. And Jim Welsh has presented some of this data publicly, but you know, it was good to see that it was also tolerated. You know, we did have a case of pericarditis where we learned to be a little more careful with the heart dose. But you know, the good news is you can give chemo, radiation, and immunotherapy together, and it's tolerable. And there will be randomized studies that come out, you know, in the near future that tell us whether it adds benefit. But at least we know it can be done.
I think we still have to be a little bit cautious, though. I mean, going back to non-small cell, where there are also lots of studies now ongoing looking at concurrent chemotherapy, radiation, and immune therapy. While the early results are promising, there's definitely the toxicity is higher. And so I think we need to be cautious not to say that it's safe and we can do it until we get a little bit more. Maybe I'm just being a little bit more old school than you, but I think we need to be cautious still. These are not things that should necessarily be done widely in the community yet.
Yeah, well, yeah, I mean, just to be clear, obviously we need to get the randomized data to say if it prolongs overall survival, but when you're dealing with a patient population where the vast majority end up recurring, you know, our long-term cure rates for small cell are, you know, in the neighborhood of 10 to 20%, you know, depending on the studies, and for non-small cell with chemoradiation, a touch higher than that. You know, I think it merits an aggressive approach if we're really trying to increase cure rates, and that's the goal here. So I certainly wouldn't say to dismiss the toxicities, but you know, if we do have a chance to increase cures, I think we need to be mindful, but not slow going into these things.
No, but the trials are accruing, and I just think we need to be cautious. I mean, in small cell, I think there were a lot of people who assumed that the maintenance was going to be a positive trial, and it wasn't, right? So we can't always assume that it's going to be better, so.
We shouldn't be swayed by the old saying, you know, don't confuse me with the data, I know what I'm doing.